Hi everybody, this is Dave Kirschner, and today we're talking about training exercises in needle guidance. Now, I've taught at a number of seminars, courses, conferences, residency programs, and what I found is that sometimes we break into smaller parts something that probably could have been trained as a whole or as simply one thing. We teach central axis one day, peripheral axis the next, nerve blocks by someone else, joint aspirations, MSK injections, when at their core, really all of these have in common needle guidance. What tipped the scale for me and made me want to record this and share this was a paper that came out in 2019 from the Canadian Journal of Emergency Medicine. This group of educators looked at residents and how they learnt about central venous access. They broke it into parts and they basically asked, hey, how do they do if we separate the components that we're asking of them? This blew my mind, and I thought, this is exactly how we can look at learning things like needle guidance. I know that might not be what they had primarily hoped the reader would take out of it, but it sure is what I took out of it and prompted me to want to think about this more and create this video. Okay, so this is how memory and doing things usually works. We use our senses, they pass along information, and we get a sensory memory. Now, as we pay attention to certain things out of our sensory memory, what happens is we have our working memory. It's that memory that we use when we're actually doing something. Now, in the process of actually doing it and thinking about it, we can encode into our long-term memory. And if we do that, what can happen is we retrieve out of our long-term memory to bring it back to our working memory. As we rehearse something, we're basically bouncing around the ideas and the thoughts and the procedure between working memory and long-term memory, back and forth, back and forth. And this is what creates those stronger synapses to help us be able to retrieve it better. However, what happens sometimes is while there's that sensory memory there and the working memory, there can be interference. In addition to that, if we think of our long-term memory, if we don't use it, what ends up happening is that knowledge decays and we end up with memory loss. And this is what we're trying to get away from. But if we take a step back from memory loss and we say, hey, let's just look at that sensory memory, the working memory, and the long-term memory, well, what we realize is that when we're doing a procedure such as needle guidance, we are working squarely within that middle zone working memory. If I think of some of the common steps when I'm doing something that's needle guided, I've got to set up the machine, get the supplies ready, get the patient set up, I've got to get the area of interest lined up, insert the needle while keeping it in plane, and then finally, whether it's going to be threading the catheter, putting a guide wire, aspirating, injecting, whatever, these are the basic parts. I've kind of jumped over them, including proper sterilization and cleaning techniques, even though it is important. The reason I've done that is if I look at all of these steps, the ones that take the most working memory for us are these two right here. Getting the area of interest lined up and inserting the needle while keeping it in plane. If we could, instead of having to keep all 5 of these things in working memory at the same time and requiring the same amount of cognitive input, what if we could work at getting really good at these 2 areas here? Let's just get them well encoded into long-term memory before we even touch a patient. Then at the end, once they're in long-term memory, let's just add on the different parts of the anatomy after to do a nerve block or to aspirate a joint or to put in a central line. So let's talk for a minute about getting everything lined up. Our goal is to get ourselves, the area of interest, and the ultrasound machine into as near a straight line as we can without too much rotation or flexion and extension of our neck. Here's what it might look like from a bird's eye view. We're going to try to have ourselves looking straight ahead at the ultrasound machine, but between those two, we're going to have our area of interest here. We are going to try to have this lined up nicely, and then as we insert the needle into the area of interest, it will be coming straight out from us towards the area of interest and then toward the ultrasound machine. This is a beautiful image from NYSORA, the New York School of Regional Anesthesia's, man, I can't say that, the New York School of Regional Anesthesia's website. And here you can see that they have good technique for lining everything up again. We have the provider right here and the ultrasound machine, and this is the area of interest. And although they're not lined up on the same kind of height, we still have the straight line from the provider to the ultrasound machine, and they're going to try to come in along that same path with their needle as they're going into the area of interest, which in this case looks like a lower extremity. Now, these are the lines of sight that we want to have when we're actually working on a patient, but we can still use those same principles when we're working on a task trainer. This is the equipment that I use when I train. Now, I don't have any stakes in Blue Phantom. It just so happens that that's the only Phantom that I have at home. But a piece of tofu or something else that has allows for good visualization of a needle would do just as well for this type of training. So I'll use the task trainer as well as the syringe and the needle. So if this was in front of me, what I would be doing really is I'd have I'm kind of near to the Blue Phantom, and I would have my ultrasound machine kind of far from it. I'd take the needle, line it up, and I'd be coming in straight like that so that it's going from me towards the ultrasound machine. When I do this, there are different skills that I practice, and these are skills that I would strongly encourage you to consider practicing on your own on a task trainer. Work on going below a proximal object to get to a distal one. Go above a proximal object to get to a distal object. Try to go between two proximal objects to get to a distal object. Try to tap two targets with the needle tip on the same pass. This will take a little bit of maneuvering, but it can be done. Try to tap a pin, which is in its long axis, with your needle, which is also in long axis. And finally, tap a pin seen in its short axis with the needle in long axis. Again, the idea behind this is to get very comfortable with following a needle, guiding your needle where you want it to go in a 2D plane as you get everything lined up. Now, this is what it looks like. In this case, we're going to go above an object to get to a distal target. On this task trainer, these are two vessels, and this is a third vessel. That's going to be our target in each of these cases. So we're going to go above the vessel that's in the near field to get to the distal one. I can see my needle coming in. I've had to change the angle. I lose it, so I sweep side to side. I can see the needle tip again, and now we are in the target. And I can pull out. The next goal, this time, we have a vessel that's proximal. We're going to try to go under it to tap the needle into the vessel that's further away. Again, changing the angle of the probe a little bit, sweeping side to side if we lose the needle tip. I've rocked the probe away from my needle, and that's made it more horizontal so it's easier to see it. And withdraw. In this one, I'm going to go between both of those vessels to get to the far field vessel. In this one, we're going to try to hit both of these smaller vessels with the needle on the same pass. For the first one, it's quite horizontal compared to the probe, which is why we see that reverberation artifact. It's steeper now, but the needle tip is still visible, and it's just entered that second vessel. You can make it harder for yourself on a task trainer or piece of tofu, whatever you're using, by modifying the location of the two targets. In this case, the one that's further away from me is more superficial, and the deeper one is near me. So I need to, again, rock the probe away from me to try to bring that needle tip to be more perpendicular so I can see it better. And there it is. Now, this shows a pin in its long axis with my needle coming in. You will be able to feel that you are actually hitting the needle the pin with your needle when you do. Just try hitting it a couple times. And then there we've moved it to the short axis, the same pin. Now my needle is coming in long axis, hitting it, needle goes above, hit it, needle goes below. If ever I lose track, I stop and I move side to side. So again, those are exercises in needle guidance that I would strongly suggest. Practice each of them at least weekly. The reason I say this is that if, again, you're able to apply these principles, you will be very, very prepared from a psychomotor sense of this component, and then we can just add in different parts of anatomy. So you're going to practice. Eventually, we'll talk about learning the anatomy surrounding the area of interest. This is when you look up your anatomy textbooks. You scan it before you're actually going to have to inject or withdraw. And then you add the other components, such as setup, cleaning, and then working on the dexterity for threading something, injecting, aspirating, so on and so forth. Now, putting it all together, what I'd like to show you next is a video of how I actually do this real time. You'll hear me say that this is how I set up as though I were doing a single shot nerve block. Again, I cannot emphasize enough that I have not gone over all of the cleaning techniques that I use when I would normally do it. The goal again is to show the setup for trying to set yourself up for success with an in-plane technique for needle guidance.
Hi everybody, so now let's put together what we're actually going to do when we're doing a needle guided procedure. So step one we talked about was getting us set up. I've got myself, I've got my ultrasound machine right here, and then I've got the area of interest right here, this trainer. First thing that we're going to want to do is have a look at whatever the area of interest is. I tend to wrap the cord around once so that it's not going to be pulling on me, and then I'm going to put it on the area of interest. If I were to look up here, I've got my machine set up and I've got something that looks like my area of interest on the screen. This is the time. Step two, I'm going to set up my machine. So now I'm modifying the depth. I want it kind of in the middle third of my screen. If there's an important structure underneath, I might want to see more or less. I'm also going to change the focus like you can on some machines. And finally the gain. Okay, and that looks pretty good. Then what I tend to do for myself is I'll look down. Might have an anatomic landmark here. I'll take the probe off, put the probe back on, not having changed any settings, and look again and say, hey, am I still happy with that image? And in this case, the answer is yes. Okay, so now I feel like my machine is set up. Next, I've got to get my equipment ready. Okay, so at this point, usually I'll still be talking to the patient. I put the probe down, and these are the basic bits of equipment. This is as though I was doing a nerve block. Got some 2x2s or 4x4s in theory. Gel, as though I didn't already have it on the patient, syringe with something to inject or withdraw, and finally, alcohol or other cleaning pads. One of the problems I see is that people don't have everything open and ready. So I'll get my 2x2s out and they're ready. I'll make sure that the cap is off so I could do that one-handed. The gel is open, and finally the alcohol swabs are also readily available. So I can just do them one-handed with my dominant hand. Now that that's ready, I have the patient set up. I'm going to look back to the screen, make sure that I might hit the trackball once or something like that on your machine just to make sure that it's not about to fall asleep. And I'm going to get my image again. So I put the probe on, I'm stabilizing with my 4th and 5th digits, and I look up and I center my area of interest. We're going to assume that this is the target and I want to access it with a needle. So now, with that hand stabilizing here, I come over here. Maybe there's some excess gel. I'll wipe that off first. Normally I would have more of these. Next thing what I'm going to do is I grab my alcohol swab. Clean, 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 clean. Maybe I've pulled the machine a little bit. I look up. No, I'm stabilizing with my hand. Everything's still in place. Come back down here. Wipe, wipe, wipe again with whatever cleaning product I have. Hand is still stabilized. Check up again. Everything's in line. I grab the needle. I leave the cap there, and now I have my syringe. Now what I'm going to do is I'm going to do an in-plane approach. So I come in. Everything is near midline. And already I can see that my needle is visible on the screen. At one point I lose it. Oh, I stop. I sweep side to side until I see it again, and then I can continue to advance. And there's the needle tip in the vessel. Remember that the needle will be easier to visualize if the beam is more perpendicular. So in this case, I will rock the probe away from me, and sure enough, it's easier to visualize. I might inject or withdraw, and then what I'll do is I will pull out. Do that, put my cap back on. I know that's not full protection there. And then what I'll do is I'll take my 4x4, 2x2, put it over the area that I punctured, and we're done. Those are the basic steps that I do for a nerve block, but also for venous, I shouldn't say venous access, but just needle guidance when I'm training with the task trainer.
So that's it, everyone. Again, I can't stress enough that I think if you take time to get good at needle guidance on some type of task trainer before you add in the other components, whether that's flicking off a peripheral IV, threading a guide wire, starting to aspirate, you will find that once you do add those components and are at the patient's bedside, things will go much better. Thanks.